今個月嘅 Hot Talk in Pediatric and Child Health， 我係香港兒科醫學會嘅會長Dr. Patrick Yip 葉柏強醫生，歡迎大家。我今個月咧開始咧，因為接觸過好多唔同嘅同事同朋友啊，原來咧大家參加咗成年嘅Hot Talk in Pediatric 咧，都唔知原來我哋幾個咧係喺香港兒科醫學會嘅會址嗰度舉行嘅。咁所以咧，今日我哋啱啱好辛苦咧，經我哋前會長阿力咧做咗個新嘅 backdrop， 咁所以先介紹下我哋好靚嘅 backdrop 先。我哋其實咧每一個月咧逢禮拜二嘅傍晚6點半咧，都喺翻我哋嘅會址，我哋嘅 office bearer 一齊喺度咧，就歡迎大家參與我哋嘅 hot talk。我哋其實兒科醫學會嘅新會址咧，我哋大概買咗2年到啦，係喺中環永吉街永怡商業大廈6樓 B 嘅。歡迎大家得閒嘅時候上嚟探我哋。咁咧嗱，我先介紹今日我哋一齊出席我哋幾個靚仔靚女我哋嘅內閣先。我哋嘅前會長阿力啦。最靚仔係趙醫生，大家知啦。我哋香港就最好嘅pediatric surgeon， 仲有就係當然我哋最靚女嘅副會長 Jenny 啦，馮寶芝醫生，大家好。當然好重要，我哋嘅 secretary Dr. David Low， 咁我哋今日最後一堂咧，就特登喺今個晚上咧，歡迎我哋今日嘅講者，香港大學我哋藥劑學系嘅講座教授 Professor Ian Wong 黃志基教授。大家咧可能如果一路對小朋友嘅健康啊，對藥物一路有興趣嘅話咧，其實Ian 咧係應該大家都完全唔陌生㗎啦。Professor Ian Wong 咧本身係喺香港長大，但係就一陣有機會你可以講下啦，就轉之後咧，就大部分時間咧就去咗英國嗰邊咧去服務我哋喺英國嘅 population。但係好難得咧，過往呢幾年咧，Ian 咧就重新再翻嚟香港，所以呢幾年咧我哋有機會同Ian合作啦，又喺Professor Wong 身上咧，其實學咗好多關於藥劑學嘅知識。咁Ian 除咗係一個藥劑學嘅講座教授，亦都係英國 UCL 其中以前嘅 department head 同埋一個最重要嘅歐洲學者之外咧，其實佢亦都係世界嘅大數據嘅研究專家。咁今日咧，我哋係非常高興咧，可以邀請咗Ian咧，同我哋分享翻喺香港我哋疫苗接種 COVID19 vaccine 嘅一個 pharmacovigilance study。嗱，大家知道咧，新冠肺炎疫苗嘅接種咧係由今年3月份開始嘅。先開始係科興，但係之後咧 BioNTech 亦都要差唔多香港有接近70%嘅人口已經打咗針㗎啦。咁喺過往咁多嘅經驗入邊咧，其實每一針嘅疫苗接種咧，衛生署同埋香港我哋嘅醫院咧都係有記錄嘅。咁所以咧，Ian咧就非常之好咧。過往呢大半年咧，其實佢統領咗香港所有疫苗接種嘅數據，就其實搜集咗好多關於疫苗接種嘅副作用，包括咗一啲比較嚴重嘅副作用，好似面癱啊、心肌炎啊，亦都包括咗啲比較輕微副作用。咁今日咧好難得咧，Ian咧係會分享翻過往呢幾個月好多嘅經驗，特別喺香港我哋發現咗好多好新嘅現象咧，可能喺外國咧都係剛剛發現嘅。咁喺完咗今日嗰個 talk 之後咧，Ian咧當然會非常之好啦，可以大家問問題。嗱，今日咧我哋嗰個問問題咧，就請大家留翻你哋嘅問題咧喺 chat box 嗰度。一陣咧，我會代表大家睇一睇翻 chat box 嘅問題咧，再同翻Ian傾偈，去分析翻有啲比較重要同埋貼身嘅問題。嗱，先提翻大家，如果大家係醫生或者護士，需要攞 CME 或者 CNE score 嘅話咧，記得先入一入我哋個 QR code 去填咗少少資料。到準時7點30分咧，我哋個 QR code 咧會再出翻嚟，等大家可以 log out 嘅。或者我先將時間交翻俾 Ian Professor Wong， 多謝你 Ian。
OK， 唔該晒。你聽唔聽到我講嘢？
聽到㗎，聽到。
聽到啊。
OK good。咁我就 share 咗個 screen 先啦。OK， 咁你哋都見到個 screen。Excellent。OK， 咁唔該晒 Patrick， 你即係嘅 introduction 啦。咁就其實今日同大家都係即係傾一傾呢一個 COVID-19 vaccine 嘅一個 safety monitoring 啦。咁我會主要用英文講。咁我哋今日嗰個talk 啦，咁我哋個 program 叫 Care Program 啦。It stands for the COVID-19 Vaccine Adverse Event Response and Evaluation Program. So basically, I need to acknowledge the funding from the Food and Health Bureau. It gives us the funding to conduct this particular study. And also specifically happy to thank the colleagues from the Drug Office of the Department of Health and hospital authorities for providing the vaccination and clinical data and also my wonderful team in University of Hong Kong. They've been working really hard. So I have some disclosure to start with. I'm a member of the Pharmacy and Poison Board of Hong Kong. So that is the regulatory authority or agents in Hong Kong to license medication and also the vaccine. And also I'm a member of the expert committee on clinical events assessment following the COVID-19 immunization. But all the opinion here is my own opinion, is not representing the expert committee opinion. And also I'm a member of the advisory panel on the COVID-19 vaccine, which allow the emergency use of the COVID-19 vaccine. And again, it is my own opinion of today's talk. So for today, I'm going to give you some of the background and the introduction of the CARE program. And also I give you 3 specific examples to demonstrate how we use the data from Hong Kong to monitor the safety of the COVID-19 vaccine. The first one would be intensive monitoring study looking into some of the frequent adverse events. And also we're looking at myocarditis following the BioNTech vaccination in children. And finally, I will talk a little bit about a Bell palsy study after the coronavax vaccination in adults and give you a summary of what I think about the vaccine and also how to use the data in Hong Kong for vaccinations safety monitoring. So give you the basic background to start with. It is quite an unusual situation. We use the Hong Kong regulation, the CAP 599K, which allow us to use the emergency use of the COVID-19 vaccine in Hong Kong. And so it is an emergency use, so it's really important for the government to conduct a pharmacovigilance program to monitor the safety of the COVID-19 vaccines. And I think you also know that the Hong Kong government have also set up a compensation fund to allow people, if they suffer from the serious adverse reaction to the vaccine, they will be able to seek compensation. So there are very important for us to actually monitor the safety of it. And in Hong Kong, we are actually pretty unique. We are one of the places actually have both coronavac and also the BioNTech one. I think most other countries, they either have the BioNTech or they have the coronavac, but we actually have both of them. So it's pretty unique situation. So the CARE program itself is part of the enhanced pharmacovigilance plan of the Department of Health. So basically it's led by the University of Hong Kong. We are doing it on behalf of the Department of Health so that we can monitor the safety of it. It is a 3 years research program, start with COVID-19 program in February 2021. So we coincide together. So we've been working really hard since Christmas until now. So there are things that we are really interested in. It's called adverse events with special interest, AESI. So you probably will see this type of wording regularly in literature, talk about the safety monitoring of COVID-19 vaccine. So it's approximately about 40 different conditions endorsed by the WHO's Global Advisory Committee on Vaccine Safety. So this particular list are used by European medicine agents. They created a program called Access Program. The Access Program basically to monitor different AESI. They include the Bell palsy, Guillain-Barré syndrome, heart failure, acute liver injury, acute kidney injury, COVID-19, and also monitor the maternal and fetal outcomes. So for the CARE program in Hong Kong, it is a pretty massive program. Within it, we have 4 different parts. The first part is actually looking into the background rate of the adverse events of special interest. So we're basically using the HA data, looking into the last 10 years of the background incident or background rate of the AESI, so that we can have understanding. So what is the background look like? For example, Bell palsy. Bell palsy do occur naturally, although it's not common. It's still occurring in the natural environment without the COVID-19 vaccine. So we need to have the background incident to allow us to understand, whether we're seeing something higher than what we expected. And then the second part is the active surveillance of the AESI. So we monitor the H8 record looking into the people, they have specific AESI, for example, Guillain-Barré syndrome. So we're looking into whether people, they are admitted to hospital with the Guillain-Barré syndrome, and then we're looking into whether they have the vaccination or not. So that will be a weekly surveillance program to identify all the serious adverse events with a special interest. And then the third one is a major part of this particular program. We use the record linkage technique to link up the data from the HA as an outcome data with the vaccination records of the Department of Health. And this is the first time that we're doing such a large scale linkage data from two different departments of the government. And the final one, we do intensive monitoring study. We go to the vaccination center, physically consent the patient to allow us to follow them up regularly and looking into some of the frequent adverse events so that we can also understand not just the serious one require the hospital authority admission or A&E admission, but also some of the relatively milder but frequent adverse event. So I'm going to give you the examples of different part of the study. So the first one I'm going to start is actually looking at the intensive monitoring study. So this is the one that we actually go into the vaccination center or the general practice primary care physician to recruit patients. So this time we specifically just looking into BioNTech one at this particular point. The reason is because today's talk is including children, and we know at this particular point only the BioNTech vaccine is used in children, and the Sinovac one is not being used. The CoronaVac is not being used for the children. So that's why this time I only showed you the data so that you can have some understanding for the children compare with the adults and also elderly. What is the adverse reaction profile or the reactogenicity? What does it look like? So we offer the government start to offer the vaccine to the children since the 10th of June. So there are case reports suggest children, their reactogenicity is actually stronger than the adult. So what we did is we did a prospective cohort design, and participants receiving the BioNTech vaccine at the community vaccine centers, we recruit them, we consent them, and then we send them regular follow-up and allow them to actually report the adverse reactions. And then we collect the data on the day when they have the vaccine, the baseline, and then first day, second day, third day, 7 days, 14 days. We use statistical analysis. We use the generalized linear mixed model to analyze the data. We simply classify them into local, so local reaction, pain, swelling, redness, itchiness, systemic, tiredness, fever, chills, muscle pain, nausea, diarrhea, rash. And also we classify some of the things as severe, like hypotension, dizziness, and wheezing. So we recruited 2,531 participants on the 21st of August. The top 5 most frequent observed adverse reaction across different age group are pretty similar. They have the local pain, tiredness, muscle pain, headache, fever. So you can see that, whether you are younger, older, or elderly, they all have the similar type of adverse reaction to the vaccine after the vaccination. But in general, they are the thing that you would expect to see. For the 12 to 17 years old, we have over 1,000 children. And then 18 to 59 years old, we have 759. And over 60 years old, we have 756. It's very labor intensive. So you imagine, we physically actually recruit them. And after that, we follow them up with the regular phone call and WhatsApp and text. Oh, we're looking into some of the severe reaction in children in here. Quite a few children, they have the dizziness and wheezing. They are quite small. But something that it was quite unexpected. We actually saw one case of carditis out of 1,000 children, which is quite unusual and quite unexpected. But if we're looking into statistical analysis, looking into different age group, we specifically want to look into the age group of compare with the middle-aged adult. What we mean by middle age is basically is from 18 years old to 59 as the reference group. And then we can see in general, we can see in here, in general, that the children, they seems to be having a higher relative risk than the middle-aged adults. But clearly that the older people, they have less self-reported adverse drug reaction than what we see in the middle-aged group, which seems to quite fit into what we think about children tend to be having more reactions than the middle-aged people, and then the middle-aged people have a bit more than the older people. I can't give you a precise, definite reason behind it, but we believe that it's all about the reactivity to, according to the immune response. Then it's not surprised that the older people, the elderly group, their immune response would not be as strong as the younger people. And that may be the reason why they are less likely. And indeed, you're looking into here, most of the analysis is showing a statistical significance lower than the younger adult. And in children's side of it, we don't reach a statistical significant level, but you can see there is a trend of lower reactions, relative risk compared to the adult side of it. So there's some implication that we need to consider. So in general, we see that the adolescents have a moderate higher risk of local and systemic adverse reaction than the adult vaccination. And also the other thing that we also notice, there's a tendency of the adolescent adverse reaction lasts a bit longer in our study. Now we must say that it is self-reporting, so we cannot be sure whether because the children feel that it is a bit more difficult for them to cope with the pain and also different adverse reaction, and that may be the reason why they feel it lasts longer. So we can't exclude this possibility, but in general, they do feel worse than the adult side of it. But we have the sample size is still quite small. Although we have over 1,000 children, it is pretty decent sample size for any prospective study. However, we still don't have enough sample size and the statistical power to look into the rare adverse event. But I must admit that I was pretty surprised to actually see one case of carditis, even out of these 1,000 children. So that was unexpected. So I'm going to give you the next example is looking into the carditis. You know, we, as I said, that we were surprised to see one case of carditis in 1,000 children. So clearly that for you guys, you know, working in pediatric side of it, this is probably the most concern you have is at the moment, everybody is looking into the carditis situation. So this time we use the Part 2 study using the active surveillance of the AESI. Basically, we actively to collect the data from the HA and also from the Department of Health. The part of study, I have to say thank you to Patrick, because Patrick is leading this particular study as the one of the investigator of the CARE program, with also a colleague from the pediatric side of it, like Mike, Gilbert, and Rob. They've been working really hard looking into the carditis side of it. So just give you some background side of it. The carditis is pretty rare, actually, most self-limiting. The incidence rate of myocarditis is about 20 per 100,000. Now, I deliberately highlight the person year as red color in here. There's a lot of misunderstanding about, you know, the background incident. Because looking into here, a lot of people misunderstand or misinterpret the information. They say, okay, it means that any 100,000 people have immunization, that 20 of them have carditis. This is completely wrong. The reason is because people at risk of carditis after the immunization would be a pretty short period of time, probably 2 weeks. So you follow people up for 2 weeks only. So effectively, if you actually change person year into person week, or just looking into 2 weeks, then the incidence of 2 weeks of following up for 2 weeks for 100,000 people, it will only give you about 1 person per 100,000. So it's actually very small. And that is for 0.5 actually. And it's very small risk. And a lot of people misunderstand about background incident. And that's why in the past, we hear a lot of people say that, okay, it's no higher than the background incident of the palsy, no higher than the background incident of myocarditis, no. But actually, because they misunderstood how to calculate the incident rate, using the person year and using the statistical side of it, looking into pharmacovigilance, we don't use person year most of the time because it actually will give you inflated information. So our colleagues collect the case report of carditis following the use of the BioNTech vaccine. And one of the problems is we start to actually looking into the literature in the world. There are lots of cases of the carditis being reported. And we know that in the literature, talk about significant proportion of this report are in younger male, and specifically after the second dose. The recent study from Israel, the Israel cohort study of about 1 million people, they identified the risk of myocarditis is about 3.24. So what it means is, it means that the risk of having the carditis is about 3 times higher than the people without having the vaccination. But of course, they didn't compare with the control group. What they compared was the background incident. So what they try to say is, if after the people have the vaccination, the risk of having the carditis is 3 times higher than the year before. That's what it meant. So looking into our own study, we collect the vaccination records from 14th of June to September of 4th from the Department of Health of all adolescents aged 12 to 17. And we collect the cases of myocarditis and pericarditis from the AIR system, the Advanced Incident Reporting System from HA. I think most of us are very familiar with it. And also to give the credit to our pediatrician colleagues, and they actually went through the cases in detail, and using the recognized definition of the cardiovascular injury coalition for epidemic preparedness innovations, and also the Brighton Working Group definition. And also they're looking into myocarditis and pericarditis associated with vaccination if within 14 days of either the first or the second dose vaccination. And we also use the data we had previously, looking into from year 2011 to year 2020. So looking into the last 10 years average, and try to compare those average with what we see after the people have the vaccination. Again, we calculate the background incident rate. We use exactly the time period that we have for the vaccination period, but looking back into the last 10 years, because there are potential of variation due to the different seasons. And also we specifically compare with the same age group, with the same gender, so that we actually control the age, the gender, the seasonal variation. So give us the best estimation of background incident. Calculate per person per days. The reason the data that we have, almost all children have the myocarditis or pericarditis within 14 days. So it's no point to follow the patient up after 14 days. If we do so, it actually, again, change the calculation and make the statistic dilute the potential side effect, the statistical side of it. And that's why we use 14 days. And the denominator of the past incident or the previous incident, we use the data from census and statistics department for the population of 12 to 17 years old. So this is a diagram to represent how we did the calculation. So we started the study on 14th of June. So we're looking into the day of the first vaccination and then follow the people up to identify people they have the carditis or pericarditis, so that we can actually calculate the incidence within the 14 days. But then after 14 days, then it becomes not at risk. And we follow them again from the second dose and calculate this particular incident in here. The whole study ends in the follow-up end date is 4th of September. So each person will have at least 14-day follow-ups. So these are the results. The results in here show that we have 178,000 adolescents vaccinated with the BioNTech in Hong Kong. 33 cases of acute myocarditis and pericarditis following the vaccination. They give us the overall reporting rate of acute myocarditis was for 18.52 per 100,000 vaccine recipients. For the first dose, we can see that in here, the rate is much lower. It's actually 3.37. Majority of the cases actually occur after the second dose. We're talking about 21 cases per 100,000 recipient. So it's 6 times higher than the first dose. And clearly this has a significant effect on how we manage the risk of carditis in children. So we are also looking into compare with the data from 2020, which is the year before. Like we can see that between the male and female, the male one is highly significant in the rate that is very high. You're looking into the background incident in 2020 using the same age group, and then you can actually looking into the number of cases is so small. We're talking about even in male 0.21 per 100,000. So equivalent to 500,000 children only have 1 case in the H8 for the 2020, if you use the same calculation for 14 days. So you can see that it's very low. But if you compare with the male side of it, it's already talking about 5. So it's much higher than what you expect to see. And then you're looking at the second dose even higher. This is what you expect to see in the population using the background information. It's about, again, it's 0.21 per 100,000, equivalent to 1 case, 500,000 people, children, when you follow them for 14 days. But we actually saw 37.32, so it's much higher. This is year 2020. As you know, the 2020 is a really peculiar year. This year, we have most of the time we are in lockdown, social isolation. We know majority of the myocarditis are related to infection. So for the year 2020, we have very low rates of COVID-19 infection. At the same time, because everyone isolated, they also have a much less infection for any other illness. So it makes the carditis probably specifically low. For this reason, the team got to also looking into the background incident before the 2020. The team looking into the background incident between the 2011 to 2020, you can see that it's slightly higher immediately in the background incident, but still very low. It's still talking about 400,000 children will have 1 case. You can see that in here, 100,000 children, we see male, we see 32 cases. So much higher than what we would expect to see, even compared to the last 10 years background incident. Oh, but one of the things that we need to be aware of, the data we have very comprehensive HA database. Is just marvelous. It's a wonderful data set to do any analysis. But the problem is we don't have the data from the private hospital or private practitioner. Said that, you know, if HA is treating most of the patient in Hong Kong, and the number is still so low, we're still talking about 1 in 500,000 of children, then even though you say that another double, let's say we have another, they only about 50% of the cases been identified, but from the HA for the last 10 years, we're still talking about only seeing 2 cases per 100,000. We should not see about 30-something cases. So it gives you some sort of understanding. The background incident is really, really rare, but what we see in here is well beyond what we expect to see. But there is also another issue that we need to be aware of is you guys, pediatric healthcare professional and even the parents, general public are much more vigilant due to the understanding of the potential carditis following the vaccination. So that may actually increase the detection. So that may have an effect. But again, with the effect so huge, making it so much higher than what we expect to see. But you're looking into here, we can see that the overall incidence is clearly the first dose is much lower than the second dose. So the second dose is actually 6 times higher. Now, based on this particular evidence, if we are going to actually reduce the risk, what do? We would actually looking carefully. Now, one of the challenge for us in Hong Kong, like this is probably not a problem when you are in England or America, because the infection rate is so high, and specifically in children, due to the most of the adult in, let's say, where I come from, UK, most of the already have the immunization or infected already, but the children are not. So majority of people got infected right now is actually in children. But in Hong Kong, we have this particular challenge. We have far less infection. So when you calculate the risk and benefit, then the balance actually tipping towards to do the risk minimization. So at the moment, we hardly have any children got infected, and particularly locally. Then in that situation, that will be arguable whether the risk of having the carditis can be justified. So the Joint Scientific Committee actually recommends single dose. As you can see in here, if you actually stop the second dose, you can reduce about 37 cases per 100,000 doses. Then in that case, that could be justifiable. But there are a lot of unanswered questions. So one of the things that I want to ask the question is, when we're looking into the US, the CDC data, they talk about 6.7 reported cases in male population 12 to 17 years old per 100,000 second dose. But what we see in our cases is 37.32. We are about 5 times higher than them. So this is something that we need to bear in mind when we see the cases, the number of cases that we have in Hong Kong. So they are unknown, but need to know very soon. Because we are so effective, we are able to actually monitor all the adverse reactions so good that the care program so successful, we got all the cases, and so we monitor this. That's why we have a high detection rate, 5 times higher than them. Could be, but there's also another possibility. Do Chinese teenagers respond differently? There could be genetic differences. And how much protection are we using a single dose when we change to single dose? That's the question that we do not know. Can we use alternative strategy to do the risk minimization? Can we use lower dose, but remain use the 2 doses? As a pharmacologist, I always ask the question, one size fit all is not necessarily the best. And as you know, you work in the pediatric side of it, we always know that we don't usually use the adult dose in children. So the first time when I heard that the children use exactly the same dose for the vaccination, I did actually ask the question, should we use the same dose? I do not know the answer. But also there's another interesting thing that if you live in UK or USA before, you do know that the teenager is so much bigger, taller than our teenager in Hong Kong. So are we using the right dose? I do not know. Or can we actually have a longer gap between doses? Now, assuming the carditis is some sort of immune response to the vaccination, then if we leave a longer gap, would it reduce the potential of the inflammatory response due to the immunization response? Again, I do not know. And I think those are the questions that we need to have the multidisciplinary team to work together with the immunologists, working with the pharmacologists, looking into the both sides of how to do some modeling to looking into what will be optimum dose for children. There's no secret of those things. And we work in pediatrics so many years. We know all about, cannot use one size fit all for our children. So the final bit I want to talk about is the Bell palsy following the coronavac vaccination in adults. Notice some of the nurses in here, you might have heard part of this particular talk in the Society of Hospital Pharmacists that I did last month or 2 months before. So bear with me if you heard it before. So we're going to use the intensive monitoring, we're going to use the Part 3, we use record linkage study. So as I told you earlier on, there are 40 odd different conditions that WHO is specifically interested in it. And for the Department of Health in Hong Kong, they also adopted this particular list. One of the items is the Bell palsy. So this study had been done few months ago. So I'm going to present the data, months ago data. So when we did the study at that point, up to the May 4, 2021, at that particular point, we have about 500,000 people of first dose of the coronavac and also the BioNTech one. At that point, very rapidly, we saw about 53 cases of Bell palsy. 33 cases for the coronavac, 20 cases for the BioNTech from the Department of Health passive reporting system. So those are reported by the HA and also by private medical practitioner. So it gave us a positive signal that maybe these vaccines causing the Bell palsy. And so at that point, the care program was set up to anticipate this type of situation. So we rapidly had to do an evaluation study looking into whether the vaccination is associated with the Bell palsy. This particular picture is actually downloaded from the South China Morning Post. Feel free to take it in the future to looking into this particular case. So Bell's palsy is a sudden onset of one side facial muscle weakness affecting both the upper and the lower face. The other symptoms may include numbness of the face, neck and the ear pain, change in taste, and sensitive to sound. So this particular patient, after the vaccination, and he had depressed, more or less is showing everything about his life. So you'd be interested to see. Possible causes, the exact cause of the Bell palsy is still uncertain, but a lot of scientists believe it's to do with the reactivation of existing viral infections, particularly like the herpes. And also maybe the impaired immunity from stress, sleep deprivation can trigger it. And also we know some other vaccines have been implicated to cause the Bell's palsy. And it affects the facial nerve, 7th cranial nerve, and make it swell and also became inflamed, leading to temporary facial weakness of one side of the face. The treatment is the Bell palsy is usually transient, so the prognosis is generally really good. 70% of them, you don't do anything, they will recover anyway. But if we also use the oral steroid treatment within 3 days of the symptoms, could increase the chance of recovery to more than by 9 months. And we also use the physiotherapy, and even though people they're not fully recover, half of them will just have mild residual facial weakness, and the remainder may have moderate to severe deficit. But basically, majority will recover. So what we did is we used a best case control study to assess the association between the COVID-19 vaccine and the Bell's palsy. So we identify all patients with newly diagnosed Bell palsy since the vaccination program started. They are the cases. So they don't have to have the vaccination. For the method of case control study, we identify cases. We don't really bother whether they were on the immunization or not, because that's how we calculate it. So what we do is we identify the cases, and then some of them would have the COVID-19 vaccine, some would not have it. Similarly, we're looking into the control patient, the people that they do not have the Bell palsy. And again, For the people without the Bell palsy, some of them would have the COVID-19 vaccine and some would not have it. Like if the Bell palsy is associated with the COVID-19 vaccine, then the patient in the cases group should see more people had received the COVID-19 vaccine than the control patient group. But that is the basic principle and the theory of the case control study is for the cases, there should be more people had the vaccine. And in the control group, there should be more people without the vaccine. That's the basic theory behind it. So this is what we did in here using the data from the HA. So, and also the DH for the vaccination record. Looking in here, we identified between the February 23rd and the 3rd of May, we identified 197 from the emergency room and also 131 from the inpatient, total 328 people with the diagnosis of Bell's palsy. And then we use a similar method to identify people without the Bell palsy between the same time using the inpatient and also the emergency room side of it. We exclude people, they are under 18 because at that point, the vaccine wasn't used in the children's side of it. So we match with the same year of age, gender, and the setting and the admission day, 1 to 4. So by doing it, we can control the age and also control the gender side of it. And also we exclude people that we do not know the vaccine status. So only a few people, because as you know, Hong Kong is very good. We have the system to for the people to book their vaccination. And so the IT system automatically collect all the data. And the cases who had a subsequent diagnosis of stroke or Ramsay-Hunt syndrome. So those are the differential diagnosis. Sometimes they can be misdiagnosed as Bell's palsy. And then also looking into people that, for example, the control, they already have a history of Bell palsy before the index day. So we have to exclude this particular group of people. And so altogether, we have 298 in the Bell palsy cases group, and then 1,181 in the control group. Also control the baseline characteristic of the patient because the baseline characteristic can affect the potential of developing Bell's palsy. So we use the logistic regression, we use the regression modeling, we use Poisson regression modeling and looking into the comparisons between the case and the control. So we compare the coronavac with the unvaccinated one. Then it clearly that it showed that what for the cases, i.e. the people have Bell palsy, the higher percentage of people actually have the vaccination. So we estimate the odd ratio, give us the odd ratio about 2.39. So effectively what it say is the risk of having the Bell palsy after the coronavac vaccination is about 2.4 times higher than the people without the vaccination. And that's how you interpret data. So when we look into BioNTech, we got a 1.76, but the confidence interval actually across 1. So effectively, what you try to say is there are higher risks, but statistically it's not significant. It means that we can't draw the conclusion to say that the BioNTech is also causing the Bell palsy, but I explain a little bit more later on. So when we're looking in the literature, there was a commentary in the Lancet Infectious Disease talk about they estimate the observed incidence of Bell palsy in the mRNA clinical trial, which including the Moderna and also the BioNTech vaccine. The vaccine arm were between the 1.5 to 3 times higher than would be expected in the general population. So what it says is actually indeed in the clinical trial, there was a signal already that potentially the mRNA vaccine can cause the Bell's palsy or associated with the Bell palsy. There was a signal in it already. Now the FDA say that they need to continue to monitor the Bell palsy in clinical use. And the company has put this as a potential adverse effect. So when you're looking into the product insert, or what we call the product characteristic summary in Europe, or the physician desk reference in America, they already put down Bell palsy as one of the potential adverse effects of the mRNA vaccine, i.e. BioNTech and Moderna vaccine. And so they put down acute peripheral facial paralysis was reported as a rare adverse event in the product insert already. But there is no such information in the Sinovac or the Coronavac. So looking at the post-marketing data from the WHO and other countries, the WHO widget-based data basically using similar to what the UK, the yellow card system, spontaneous reporting system, like the AIR system that we have in Hong Kong. They're looking into the ADR report. So basically they say that see a higher risk of the report compared to the flu vaccine or other viral vaccine. So basically they say that no higher than other vaccine. But then the problem is there are some other vaccine being implicated to cause the Bell palsy. So how to interpret the data? This is very difficult. If you compare with another vaccine, the vaccine being implicated with Bell palsy, you're no higher than them. So you're still in a square one. Don't know what's the answer. And then there was a small case control study. It's about 47 cases and 74 controls in Israel. And they say that there was no difference between there's no difference between the vaccinated group and the cases and the control. But you quickly can see that they have 37 cases. We have over 1,000 in our study. So you can see very quickly the sample size they have in Israel is just too small of both cases, and the control add together is only about 100 something. So when we did the sample size calculation, you have to have a relative risk or odd ratio about four times higher than the background before you can detect it, which is clearly that they were not powered to detect a difference of 1.5 to 3. So that's why we need to be very cautious about the data from other countries. The study, we don't know because it's no control and no individual data. Israel is just too small. So our Hong Kong study is 10 times bigger than the Israel study. So we saw a positive association, but not statistically significant about the BioNTech vaccine. The Israel people also using the mRNA vaccine. So we need to be very careful. We found the Coronavac have a higher risk. Although the BioNTech one, we also see a higher risk, but not statistically significant. So it may be to do with we have not enough power to detect such a small difference. We're talking about 1 point something only. The implication is the Coronavac, there was no publication on the association of the Bell palsy. So our study was actually the first one in the world. And so we have shown a small increased risk of Bell palsy following the Coronavac vaccination. But for the BioNTech, because they already in the package insert already say that they have potential adverse reaction of Bell palsy, so no regulatory action need to be taken by the regulator. However, the Coronavac package insert did not have this particular adverse effect. So the package insert was updated with the patient information on the DH website. So it was changed in July 2021. And also the cases report to the Department of Health have been reclassified according to our study, because in the past, we didn't know whether there was an association or not with Coronavac. So most of the cases, we classify them as indeterminate. It means that we didn't have enough information to make a judgment whether these cases reported to the Department of Health were really associated with Coronavac vaccination. So if you're looking into the website of the Department of Health, so this is, they put down, it's very, very rare adverse reaction to the Bell palsy after the Coronavac, and the incidence is less than 0.01% people would have it. So how relevant to the general public? I think the most important bit, the Bell palsy is really rare, and it's very transient. And we estimated it's only about 4.8 extra case of Bell palsy out of 100,000 coronavac vaccines received. And in general, over 90% of the Bell palsy cases, though not specifically to the COVID-19 vaccine, can be resolved within a few months following prompt corticosteroid treatment. So the benefits and the protective effect of the COVID-19 vaccine is far outweighed the risk of this general cell-limiting adverse event. So the paper was published on 17th of August in the Lancet Infectious Disease. And the Lancet Press Center actually put out a press release on our behalf. So it was quite a recognition of the work done in Hong Kong. So thank you for all the healthcare professionals are so vigilant, identify the patients that they have the Bell palsy following the 19 vaccine. So just want to, before we end, also want to talk about the current study that we have in the care program. So we actually done another study on myocarditis and the pericarditis following vaccination using the case control study design, similar to what I just showed you in the Bell palsy study. This paper is being under peer reviewed right now, and that is one of the reasons why I couldn't do the presentation today to show you the result. But we are hoping that I should be able to present the result very soon to show you the risk of myocarditis and pericarditis compared to the coronavacs. So you can see the incidence in the BioNTech one is much higher than the coronavac, and also looking into people without the vaccination. And also we're doing another study looking into, we've done another study looking into thromboembolic events like stroke, myocardial infarction following the vaccination. This paper right now is under peer review by European Heart Journal. We try not to actually present the data without the peer review because it could change after the peer review, after the international expert looking into our data. So we don't want to actually PM all the results. We're also looking into the people with the multiple morbidities, whether they have higher risk of side effect or immunization, and also safety in the people with the rheumatoid arthritis. And also another study that we've done on the Bell palsy following the BioNTech immunization. As I showed you earlier on, the BioNTech one maybe was underpowered. That's why we didn't show significant effect. So that's why when we had more data last month, we analyzed the data again. So all those papers are being peer reviewed by international journal. So hopefully in the not long future, I will be able to present all those studies to you. And also other study that we are being conducted is looking into seizure after the vaccination. We got quite a few cases of seizure after the vaccination be reported to us. And also some of the blood dyscrasia, including the thrombocytopenia, and also other adverse events. But so far so good. We haven't seen any major significant safety issue that I need to actually call upon the Department of Health to say we need to reassess the risks and the benefits. So far so good. So I'm going to give you the final summary from my point of view. The pharmacovigilance is certainly an essential part of the monitoring of the safety of the COVID-19 vaccine. Now, at the moment, we are still under emergency use under the cap 599K to allow us to use the vaccine. So we need to continue to monitor it. But some people actually ask me one of the questions to say, hey, look, the BioNTech vaccine is already having a license in America as a regular license. Why can't we give a regular license in Hong Kong for the BioNTech? So my answer is, majority of data are actually not in Chinese. They're in Caucasian. At the moment, Hong Kong is the only place the Chinese or majority of Chinese population are using the BioNTech. I don't think the BioNTech have the license in China yet, and they are sorting out the license, emergency license in Taiwan at this particular point. So I can't put my hand to my heart to say that I know all about the adverse effects, at least in Chinese. So we should monitor it carefully. And as I showed you earlier about the myocarditis, what we identify, the carditis cases in our children is far higher than what we expected to see in the general public, and also much higher than what been reported by the CDC in America. So if you say that giving them a regular license, I think it's slightly premature. So secondly, it's about the care program. We believe the care program is highly effective. We were the first group of people able to demonstrate the Bell Palsy Association, the CoronaVac. And we are probably is also the first programs have sufficient data to demonstrate the association between the Bell Palsy and the BioNTech vaccine. And again, we are able to actually monitor some of the adverse events that, like the carditis, very effective. So this type of program is highly effective. And indeed, we're so effective that the overseas collaborator contact us to ask us to collaborate with them. And the care program to demonstrate the power of the Hong Kong electronic medical record database from the Department of Health and also from the HA. This is, is something that we should be really proud that we, in Hong Kong, such a small place, we have such a powerful databases, able to provide the real world data evidence. And my understanding is HA is continuous to actually looking into how to allow safe access the data. And there will be something that I'm pretty sure within the next year or two, there will be some announcement to allow better use of the data. Now, based on the current evidence, the benefit of vaccination is certainly outweigh the risk of vaccination. And the care program will continue to monitor the vaccination program in Hong Kong. And also currently we collaborated with the Global Vaccine Data Network, and we will contribute to the global vaccine safety monitoring. And we are hoping one of the study in this particular global vaccine data network with the Hong Kong data, Patrick is heavily involved. Indeed, Patrick is driving it. He's looking into the pharmacogenomic side of it. We're collecting the genetic sample from Hong Kong and also genetic sample from all different countries using the global vaccine data network so that we can all analyze the data, whether there is a genetic difference between the Chinese and other Caucasian children. And to show, that's why we have such a high rate of the carditis, or just simply because the care program is so effective. We just don't know. We can't be complacent. So that's why we work with all other people in order to give the best evidence for the children in Hong Kong, also indeed to all the citizens in Hong Kong. So that is what I want to share today, and thank you for listening.
多謝晒 Ian。先提一提大家先嗱，而家時間咧就Ian 好準時，我哋差唔多7點半。咁咧就其實我哋仲有500位同事喺度咧陪住Ian一齊 quarantine 嘅，因為大家可能唔知咧 ，Professor Wong 喺英國咧，而家好亂咁喺酒店嗰度 quarantine 緊。咁咧就所以咧我今晚好開心啊，因為有我哋咁多好好嘅同事啦。其實今日聽阿Ian talk 嘅同事咧。 好多都真係 personal involved 喺個 vaccination program 嗰度。當然今日有好多疫苗中心，我哋幫手接種嘅同事啦，有好多私家醫生啦，有好多護士啦，亦都有好多我哋嘅老師啊，同埋照顧我哋小朋友嘅人咧都有參與。咁所以咧，好歡迎嚟緊呢段時間咧，我諗阿Ian係願意可以留多一陣咧，同大家傾一傾翻有啲你哋比較擔心嘅問題。頭先咧喺過程入邊咧，有好多我哋啲朋友啊、同事咧都 WhatsApp 咗我問咗好多問題嘅。 咁咧就，但係同一個時間咧，就如果而家大家仲有新嘅問題，而咁啱大家有冇 WhatsApp 嘅話咧，就請大家咧就直接將你嘅問題咧留喺個 chat box 嗰度。咁我會先同阿Ian一路傾住偈先，咁大家可以去 chat box 度問問題。嗱，我哋啱啱到7點半，如果有醫生或者護士同事趕住走，而又想快啲攞咗個 CME 或者 CNE 分嘅話咧，請記得咧去翻你個 QR code。 啱啱阿 Kit 開咗我哋個 QR code咧，就可以嘟翻 CME 同埋 CNE 咧登記翻先走好嘛。咁但係如果大家 welcome 可以留多一陣嘅話咧，我哋同阿Ian再傾一傾偈。好，阿Ian我想幫有啲同事問你問題先。我諗大家好 appreciate 啊，因為咧就似乎香港咧原來我哋儲咗咁多 vaccination 嘅 data 嘅。我要 admit 翻阿Ian先，之後Ian又出咗去。OK， 好，我 admit 咗Ian啦。咁咧就阿Ian啊，我想問一問你啊，我哋有啲同事問咧，原來香港咧我哋係有咁多咁好嘅 vaccination data 嘅。嗱，基於頭先你同大家分享過我哋嗰啲 vaccination data 咧，似乎好似
Dr. Yip 你等一陣，阿 Professor Wong 入緊嚟。
Hello， Ian， 你 join 咗未啊？
係啊，
唔緊要，我同大家傾住先。阿Ian好辛苦啊！頭先啱啱一完咗佢嗰個 talk 之後咧，佢突然間斷咗線，佢而家再入過嚟。咁我哋頭先有同事咧，啱啱同大家問咗個好好嘅問題咧，就係原來香港我哋有啲咁整齊嘅 vaccination data，非常 amazing。因為我諗頭先你聽阿 Professor Ian Wong 同大家 share 咧，原來我哋喺 COVID-19 vaccination 開始個計劃咧，喺外國開始就差唔多有接近1年到啦，香港大半年到啦。其實我哋好多嘢都唔知嘅。就係正正因為我哋唔知 COVID-19 由個 infection 開始到而家咧，我哋慢慢掌握多咗少少對呢個病毒嘅認識，對呢個 vaccine 咧有到底會唔會有一啲嘅輕微嘅副作用，或者有啲唔同嘢影響緊我哋咧？正正因為我哋好多嘢都唔知咧，我哋更加需要了解多啲。咁頭先阿Ian咧就同大家 share 過咧，關於 Bell's palsy 係咪？咁咧就有同事就問啦，點解好似有一個印象係咪 Professor Wong 你嘅意思係話 BioNTech 係冇乜證據會令到有 Bell's palsy， 而相反 Sinovac、Coronavac 就會 cause Bell's palsy 咧？但係啲人聽唔聽到啊？
佢都未入到嚟啊，要等一陣。
OK， 唔緊要。嗱，我哋再試下。我問一問阿Ian先。好嗱 ，Professor Wong join 嘅時候咧，我同大家講一講翻我哋嗰啲進度先。頭先阿Ian咧，其實同大家 share 過有少少唔同嘅資料。咁咧，其中一個咧就同大家提過啊 Bell's palsy 嗰個 study 啊。嗰個 study 咧，其實一個好大嘅特點咧，我哋有朋友特登問咧，就係到底我哋個 care program 跟進嗰啲有 side effect 嘅recipient 要跟進幾長嘅時間咧？嗱，因為咧就之前咧就 CDC 咧曾經有建議過咧，如果有 post-vaccination 嘅 complication， 譬如有比較嚴重嘅 Myocarditis 嗰啲 case 咧，其實可能需要跟進5年以上嘅。咁到底頭先 Professor Wong 講嗰個 care program 又會跟進幾耐咧？Ian 你 join 咗未啊？如果Ian未 join 咧，
唔好意思，唔知點解。
緊要啊，唔好咁講。好歡迎又見到你啊！大家啱啱知道原來你係喺香港 quarantine 緊，咁所以咧就可以善用多10分鐘時間同Professor Wong 你傾一傾下。嗱，有同事問咧，關於 Bell's palsy 啊，頭先你咪同大家 share 過咧，其實 Bell's palsy 咧喺最初外國試驗嗰個階段咧，曾經咪話過 BioNTech 係有機會增加到 Bell's palsy 嘅風險嘅。但係頭先你講過有唔同嘅地方嘅數據，包括香港我哋 publish 咗嘅數據咧，係咪你嘅建議係其實 BioNTech 並唔係真係增加咗 Bell's palsy 嘅風險，反而科興嘅 Sinovac、Coronavac 係增加咗 Bell's palsy 嘅風險？
其實我哋嗰個 result 咧係都見到佢係其實高咗嘅，只不過係我哋未做到 statistical significance 啫。其實我哋最新嗰個 analysis 咧都係見到 BioNTech 係高咗嘅。其實點解咧？嗱，因為不嬲大家都知啦 ，BioNTech 好似係容易啲會 cause inflammation 嘅。咁到底有咩 mechanism？ 點解 Sinovac 作為一個 inactivated vaccine， 我哋會發現其實佢增加 Bell's palsy 嗰個風險會仲高啲咧？ 嗱，其實大家都唔知嘅呢個嘢，大家都係估嘅啫。即係如果你問我 as a pharmacologist， 我就即係我 as a pharmacologist， 我嘅睇法就係咁樣啫。因為其實Bell's palsy 係一個 immune response 嚟嘅。其實你諗下BioNTech 本身咧，佢裏邊有嘅 protein 啦，或者佢裏邊即係你加埋有晒 experience 所有嘢啦，其實佢係即係佢 produce fundamentally 去 produce spike protein 嘅啫。咁但係你用一個 inactivated 嘅 vaccine 嚟講咧，其實你係將佢裏邊嘅即係 inactivate 咗個，即係你即係滅活咗嗰個 virus 咧。咁其實佢裏邊有好多唔同嘅 protein。咁所以其實我哋都真係唔知，你其實每一個人對個 environment 或者對每一隻 protein 佢嘅 response 都可以唔同㗎嘛。咁所以 fundamentally 你話會唔會有個可能性就係你裏邊越多唔同嘅 component 就越大機會會有一個 immune response 係 unexpected 嘅咧？咁冇人可以 exclude 呢個 possibility 咯。好啊，
咁你覺得其實嗰個算唔算係一個 causal relationship？ 係咪都已經可以話係因為打咗 Sinovac 之後增加咗 Bell's palsy 係一個成因？
你可以講係話佢 increase 個 risk， 但係其實你話 causal relationship 係好在乎嗰個人咯，因為你即係 fundamentally 其實做一個 safety 嘅 analysis 有兩個方法嘅，一個就 statistic， 呢個就係我哋而家成日都做嘅，就係我哋用大數據做 statistic， 但係你都要睇翻嗰個病人本身自己嗰個嘅即係嗰個嘅bell palsy 個 characteristic 啦。譬如你如果嗰個即係嗰個病人本身已經係曾經有個 bell palsy， 而嗰個 bell palsy 都係 regular 發生嘅話，咁你其實你好難 exclude possibility， 只不過一個 recurrent 嘅 situation 咯。咁所以好在乎即係本身嗰個人嗰個即係嗰個 clinical feature 同埋佢個本身 characteristic 咯。
我頭先有一個同事咧就 WhatsApp 咗我，就問咗個問題嘅。Ian，你頭先講過關於 Bell's palsy 打完 Sinovac 個風險高咗啊嘛，係打完第一針定第二針啊？如果譬如打完第一針已經發覺有 Bell's palsy， 仲應唔應該打第二針？
嗱，我哋當時其實就唔夠 statistical power 做晒兩個唔同嘅針嘅。咁但係我哋即係見到係 raise 咗咯。咁呢個其中係一個，就算我哋嗰陣時即係有嗰個 commentary 寫係 respond to 我哋嗰個 letter 都，即係嗰個 paper 都講翻話，其實仲有好多嘢係 unknown 咯。因為嗰一刻我哋真係唔夠數據去講呢樣嘢。但係其實我哋啱啱做完咗另外一個 study 就係做BioNTech 嘅。咁嗰度其實我哋有數據係見得到咯，見到其實係第二個 dose 係大啲嚇。咁當然你打完第一 dose 有事嘅時候，即係你。Again 啦 ，as a pharmacologist 啦，我嘅即係我嘅 advice 就係你打完第一針有事嘅時候，最好唔好打第二針咯，因為其實你有唔同嘅 platform 啊嘛，你唔係需要一定要用同一個 platform 啊嘛。呢個亦都係即係我記得我即係12月嗰陣時有個即係Financial Times 嘅 reporter 問我，佢話既然你哋將會有 BioNTech 嘅話，點解仲要有 Sinovac 咧？因為你其實 BioNTech 係即係 effective 好多噶嘛，你睇啲 clinical trial， 但係其實唔係咁樣做法咯，因為其實真係唔可以即係 one size fit all 呢一個 issue 咯，即係其實你每一隻 vaccine 有佢自己一個 characteristic， 佢個 profile、safety profile 啊嘛，咁所以變咗其實我哋係需要有唔同嘅 platform 咯，譬如你打完 Sinovac 有事嘅話，咁冇理由唔去嘗試用另外一個 platform 啫。
係啊，同意啊。咁另外咧，就我哋有同事問咧，頭先Ian你有提過咧，你做個 Bell's palsy 嗰陣時咧，有個好特別嘅 study design 咧，叫做 nested case control study。咁有啲同事咧，其實就有聽過 case control，即係好似有啲有病，有啲冇病咁啊比較下。咁你嗰個 nested case control study 其實佢唔係好明係點做嘅，你可唔可以介紹下？
哦，其實個 nest 個意思即係話咧，因為我哋所有嘅病人都係由 HA 嗰度抄出嚟啊嘛。咁所以點解就係其實 nested on 一個 data set 一個 database 咯，我哋其實 nested on HA 成個 database 咯，因為其實你以前嘅 classical 嘅 case control study 係你直頭去個 field 度去抄啲人出嚟，咁你嗰度抄完啲人出嚟之後咧，你可能去第二個地方抄啲 control 出嚟啊嘛，咁所以佢唔係 nested in 一個 population 咯，而我哋係 nest 咗喺一個 population 裏邊。
理解嗱，頭先咧有同事問咧話Professor Wong 啲 slide 好好啊，有冇機會可以俾佢睇翻其中一張 slide？ 咁我諗今日就未係好方便啦，但係大家唔使擔心，因為我諗 Professor Wong 咧應該會准許我哋咧，之後咧可以將今日我哋嘅 video recording 咧再 send 翻俾大家。咁咧好似以往咁啦，好似上次袁教授嗰個video 咧，我 send 咗俾大家咧。我諗之後大家可以有好多機會慢慢再重溫，咁可以再 share 翻俾你啲同事，好唔好？咁另外咧就頭先有同事問過咧，關於嗰個 Myocarditis Professor Wong， 咁咧你頭先有提過咧就香港咧就似乎因為我哋 original 嘅 data 出到我哋睇到adolescent 12到17歲打完 BioNTech 之後咧，嗰個 Myocarditis 同埋 Pericarditis 風險咧係仲高過外國。咁因為咁咧，就好似就之後香港政府咧就改咗個政策打一針，係咪啊？咁你覺得咁呢個做法咧，其實係咪外國都應該跟我哋？係Ian喺邊度啊？
佢好似又出咗去啊！等一陣先。
好，唔緊要，我暫時代住阿 Professor， 大家如果唔介意，我獻醜，我都代住阿 Professor 答先。有個同事問咧，就如果打完打咗一針嘅政策改變咗之後咧， 外國應唔應該跟我哋咧？暫時咧，其實我哋個數據係唔充分嘅，因為咧大家知道咧喺香港咧，其實香港政府我哋疫苗科學委員會包括咗林宇龍教授啦，亦都包括咗 Prof Wong 咧喺佢哋討論過之後咧，其實用咗我哋本身香港嘅數據。頭先大家聽過咧，其實香港我哋已經有40幾個12到17歲嘅後生仔咧，喺打完第2針疫苗之後咧，就發生咗有啲唔同嘅心肌炎嘅副作用。因為呢個風險咧，所以香港嘅疫苗接種委員會咧，大概喺幾個禮拜之前咧就改變咗個政策，轉咗係1針嘅。呢個咧其實喺香港嘅情況嚟嘅啫，因為咧香港相對地咧，我哋其實打完疫苗之後咧，發覺我哋第1針之後嘅小朋友咧，嗰個疫苗嗰個抗體嘅保護性非常之好，再加埋咧，相對地香港咧，其實我哋有嗰個新冠肺炎感染嗰個風險比較低啊，所以咧我諗好視乎翻咧，大家睇一睇咧，就到底你嘅小朋友第時會喺香港生活啦，定係一啲比較高危嘅地方，喺美國定係英國？如果喺香港嘅話咧，我哋一般嘅建議咧，就希望大家咧就考慮咧就打1針就已經夠㗎啦。如果去外國比較高危嘅地方咧，可能個考慮就有少少個別性啦，可能另外要再諗一諗。咁另外咧就其實頭先有朋友問咧，就係咁如果我打咗1針疫苗之後，而家我哋個新冠疫苗係轉咗打1針嘅，咁轉咗打1針之後，到底嗰個成效夠唔夠顯著咧？伊人你未 join 翻係咪啊？如果伊人未 join 翻咧，暫時我代伊人答先，唔好意思嚇。我其實作為一個主持人，邊個代啊？伊人答。
我 join 咗，不過咧
係伊人。
我 join 咗，我而家用另外一個去 join 你哋，我用我電話 join 你哋，可能好啲。
好啊，好啊，多謝你。你聽到我個問題嗬？伊人啊，頭先我嗰個問題咧就係，如果而家香港政府已經轉咗BioNTech打1針啦，咁我哋有冇留意到打完1針之後，其實嗰個心肌炎或者Myocarditis 嘅風險低咗啊？
其實而家先至啱啱開始，
係。
咁所以我哋未必有 data 咁所以我諗我哋都要可能等一等之後先會知道。咁但係好似我今日聽到，因為我哋今日開個會嚟喺 Department Health 裏邊，係我嘅 understanding 就係好似暫時好似少咗。咁但係因為都係啱啱開始咧，所以其實大家都唔夠膽 confirm 係咪咯？咁我諗再過少少時間啦，我諗俾多2個禮拜我啊，跟住我話翻俾阿 Patrick 聽 ，Patrick 可以喺下一次個 meeting 裏邊話翻俾你聽。
好啊，好啊，我哋暫時喺兒科，你知如果有心肌炎嘅個案，好多時都入翻兒科病房嘅。兒科嗰邊咧就醫管局就委派咗Dr. 咪關咧就幫手過我哋。我哋暫時喺呢個幾2個禮拜開始轉咗打1針之後咧，的確好似初步睇到係嗰個新症嗰個比率係少咗。咁但係好似 Prof Wong講咧，要等長少少時間，要翻多啲新啲嘅數據咧，就等阿伊人再俾翻我哋。另外頭先伊人你唔喺度咧，我代你答咗。咁下係就係香港我哋而家轉打1針啊嘛。咁你覺得外國應唔應該跟香港變咗轉打1針？
嗱，頭先我都講翻咧，係嗰個 risk 同 benefit 個 ratio 個問題啊嘛。因為我哋香港 control 得咁好咧，你其實你諗下，我哋真係其實而家暫時係冇乜細路仔喺香港係 got infected locally 喎。咁所以你嗰個 risk and benefit 個 ratio 就好難計㗎啦，變咗係一定係 tip to 嗰個 risk minimization 咯。但係你倒翻轉，如果你喺英國嘅話，而家係講緊即係慢慢聲咁樣惹到嘅時候咧，咁你嗰個嘅relative risk一定係 tip on 去個 benefit 嗰邊多咗咯。因為你要記住一樣嘢就係，你個 COVID-19 infection 都本身都可以 cause carditis 㗎嘛。而我哋嘅 understanding 就係個 COVID-19 infection cause carditis rate 咧係可能甚至乎係高過你嗰個 vaccination 嗰個 rate 嘅話，咁你個 balance 一定係 tipping to 俾晒2個刀水，盡快 protect 佢咯。
係啊，多謝啲人。其實阿 Wendy 咧，我哋好朋友盧醫生都問咗個問題咧，就咁如果係喺香港，但係個小朋友將會要去overseas，譬如去美國、英國，係咪都值得考慮打一齊2針 BioNTech？
我自己個人見解就係咯，我就會覺得係咯。但係個 issue 就係，即係我哋都未 Department Health 嗰邊都要即係要傾呢個問題咯。因為呢個都係一個 issue 嚟嘅。你而家暫時我哋 offer 就係 offer 1針啊嘛。咁但係其實 果你要過外國嘅時候，你成個嘅 risk and benefit 嗰個 calculation 就完全唔同晒咯。
同意理解嚇。咁咧就另外頭先都有Dr. 咪關咧就問咗一個相應嘅問題嘅，因為咪話咧 CDC 就 recommend 如果係 vaccination 之後發現 Myocarditis 咧，應該咧就好似話要suggest 我哋要 follow up 嗰啲 client 5年咁長嘅。咁到底阿Ian你頭先提過 care program 咧，你會 follow up 啲 client 幾耐㗎？
嗱，呢個就係即係 electronic medical record 個 beauty 啦。其實 fundamentally 咧，我哋呢啲 patient 咧，我哋可以 continue follow them up until the day they immigrated to other countries or unfortunately they decided they're too rich, no longer want to be in HA。咁所以其實即係話 fundamentally 我哋可以幾年之後再 follow up 佢哋咯。咁我攞翻 SARS 做例子啦。我哋上年 publish 咗個 paper 就係攞翻10幾年前 SARS infect 咗嘅人，佢跟住10幾年之後佢哋嗰個 outcome 係點樣咯？咁所以其實5年、10年，其實喺我哋做呢啲 pharmacoepidemiology 嘅人嚟講咧，係唔係一個大嘅問題咯？
係啊，同意。第一咧就我諗大家放心，因為我哋對嗰個疫苗嗰個長期後遺症都係非常關注啦。咁一來就Prof Wong 同大家講過咧，我哋喺醫管局嗰個電子嘅 database，我哋會追蹤嗰一啲 client。另外咧，其實我哋而家喺香港兒童醫院咧，我哋開咗一個新嘅 post-COVID-19 vaccination complication clinic。咁有啲比較嚴重嘅 complication咧，其實我哋喺嗰度有跟蹤緊嘅。特別係頭先講過差唔多40個我哋Myocarditis嘅個案。咁將來希望我哋會再了解多啲，等大家更加清楚嗰個長遠嘅情況。Ian，我哋另外有同事咧，就想問一問你咧，頭先你好好咧，就分析咗有好多唔同嘅副作用。但係整體上咧，而家個疫苗接種率都去到差唔多70%啦。你發覺嗰啲副作用咧，係咪好似頭先你另一個講法咧？其實係細路仔多啲，老人家少啲㗎。所以係咪因為咁嘅原因，其實老人家應該唔驚打針，快啲打？你要開聲咩？
呢個又係去翻即係嗰個 risk and benefit 嗰個 issue 咯。因為其實你睇翻喺外國咧，就係所有即係喺外國係打晒老人家先嘅。咁因為佢哋覺得嗰個 risk 喺老人家，佢哋惹到之後，佢嗰個 mortality rate 同埋佢個 seriousness 係一定大嘅，咁所以打晒嗰班人先咯。我哋喺香港就係 over cautious in a way 咧，就唔打佢哋嗰班。但係如果你話即係話fundamentally 嗰個 likelihood of 呢一個即係頭先講嗰啲 minor side effect 咧，你係見到個 age 越大嘅話，其實係越少嘅，因為佢嗰個 immune response 係應該係冇咁犀利嘅時候咧。咁所以佢 likelihood 就係 less immune response 就 less likely to have 嗰個 side effect 咯。咁如果你問我 as a 即係 public health scientist 嚟講，咁我就覺得係盡快打晒啲老人家係更加好咯。因為嗰個問題其實我哋如果成個 holistically 唔好淨係話睇係咪個 personal protection 個問題咧，就係你諗下，如果佢哋打咗之後咧，佢哋可以第時做到嘅 activity 應該係多咗咯。因為而家我哋見到其實老人院都仲係好 restricted 咧 for 啲老人家去探訪啊，或者我哋好多時要 shield 佢哋 from other people， 其實係 not good for their mental health 咯。Similar to children， 如果我哋成日唔俾啲 children 去 school 嘅話，亦都唔係一個 good thing to their mental health 咯。
好啊，嗱，有同事咧就頭先喺你講緊書嗰陣時，特登 send 嚟問我嘅。Prof Wong，你對於細路仔打 Sinovac 有冇咩意見啊？因為而家小朋友似乎未有機會打到Sinovac，你有冇留意過有一啲其他數據係咪應該有機會考慮俾細路仔打Sinovac？
我諗即係而家呢一刻裏邊，我嘅 understanding 啦，其實大陸已經有用緊嘅啦，咁同埋亦都個 number 唔細咯，即係唔係講緊即係100-200個人用緊咯，係講緊都幾大嘅幾大型咯。但係我諗有一樣嘢就係即係係可能即係喺即係 Sinovac 本身自己一間公司可能要more proactive 將呢啲 data transfer 出嚟咯，因為而家我哋嘅 understanding 就係用緊嘅。咁但係我哋冇乜呢啲數據，就係話究竟有幾多 side effect 啊？有幾多即係嗰個大型嚟講有幾多 side effect 咯？即係我又唔會覺得，我唔會覺得佢 personal opinion 啦。即係我覺得 unlikely 佢會有好多 side effect 咯。咁但係冇數據始終係冇數據啊嘛。而家始終係一個 evidence base 嘅era。咁所以佢 post marketing 嘅 data 我諗 highly important 咯。咁如果你從嗰個淨係從 antibody 或者從 immunological side of it，咁佢一定有 response 嘅，咁一定係 會 create 到嗰個即係 antibody 咯。咁但係個問題就係我哋未有足夠嘅數據喺呢一刻裏邊好 confident 就係話佢有幾 effective 或者好 confident 佢嘅 side effect profile 係乜嘢嘢咯。
好啊，我諗大家都 appreciate 到咧，透過頭先啊 Professor Wong 同大家嘅 sharing 咧，其實我哋攞準確同埋適時嘅數據咧，對於我哋理解我哋嗰個policy， 特別係嚟緊疫苗接種嗰個計劃咧，非常之重要。亦都好 appreciate 咧，其實今次個 big data 嗰個 approach 咧，幫咗我哋了解多咗好多 COVID-19 同埋嚟緊我哋嘅治療。最近咧有一個新發展咧，頭先有朋友問一問嘅咧，啲人你好似聽過最近有啲新藥咧，話對於 COVID-19 咧減低嗰個 mortality 咧，好似幾有幫助嘅。咁去咗一個 extent 咧，啲人就開始諗既然有藥醫，係咪應該唔好打 vaccination 咧？同埋仲有一個諗法咧，就最近似乎有好多打咗 vaccine 嘅人咧都仍然中招啊，特別係嗰啲 mutant strain 啊。咁係咪嗰個 vaccination 已經去到個樽頸位，大家唔需要考慮打咧？
你睇翻英國啦，即係我攞我最熟嘅地方啦，英國啦，啱啱翻嚟，即係英國都仲係講緊幾萬人咁樣惹到咯。咁但係個問題就係你唔見唔到佢當時好似即係佢，我記得佢最巔峰嗰陣時，我都喺英國嗰陣時，佢一日係死成千幾人，即係淨係死喎，唔係講惹到喎，惹到係5-6萬人啦，死到嘅係千幾人喎一日。但係你而家係見唔到，而家係見到係講緊10幾嘅啫。即係你見到嗰個打就係正正因為打咗疫苗咯。其實你打咗疫苗係不嬲都知嘅，大家都知呢個故事嘅。你打疫苗係唔代表你唔會完全可以防止你惹到咯。但係打咗疫苗係可以減低你即係 serious 嘅風險咯。咁所以其實反而呢個係重點咯。唔多唔少，即係其實開始大家都要開始有個心態，就係覺得好似傷風感冒咁樣咯。即係你打咗流感針唔代表你一定冇事嘅，但係打咗流感針嘅人通常係可以減低嗰個即係嗰個serious 嘅風險咯。咁所以我而家都係鼓勵啲人去打咯，因為你減低咗嗰個即係 serious 嘅風險已經係足夠咯。咁去翻藥嗰度啦，咁當然我哋想多啲藥係可以即係，因為始終就算而家講緊話喺英國都係死百幾，即係死十幾人到百幾人啦，就唔係千人咁樣死法。咁但係都有人係因為咁嘅緣故去死㗎嘛。咁個問題就係其實 like any other microorganism infection 就係你始終都會有一個 resistance 嘅。咁你係咪想嗰個 resistance 咁快走晒出去咧？咁所以呢個係另外一個 issue 嚟咯。咁所以就係話，就算你而家係有藥醫，但係嗰啲都唔係代表佢 100% 可以醫得翻好翻晒咯。咁所以其實係應該係 multimodal，就係去打咗疫苗。如果即係咁唔好彩惹到嘅時候，你唔係咁 serious。如果有啲人係真係自己本身免疫系統唔係咁好，而跟住係會有 seriousness 嘅話，咁當然有唔同嘅 treatment 去幫佢哋更加好咯。
同意啊，同埋我諗大家一定要留意咧，即係而家慢慢我哋了解多咗 COVID 咧，其實有一個叫 COVID long syndrome 咧，係長遠咧有機會有好多併發症同埋副作用嘅。就算香港咁好彩咧，我哋都有啲病人有啲長遠副作用。咁大家都值得留意。好多謝大家，因為我哋雖然差唔多到8點啦，但係我哋都有幾百個同事咧就陪住Ian 喺英國翻嚟之後一齊 quarantine。咁咧希望咧就大家好好珍惜今晚一個好平安嘅晚上啦。先同大家做個介紹先。你離開之前咧，請你去翻CME 同埋 CNE 攞分，同埋咧就因為嚟緊10月30號香港兒科醫學會、香港兒科醫學院同埋我哋2個護士組織咧，大家喺香港兒童醫院咧，同埋喺網上咧合辦咗一個 Joint Annual Scientific Meeting 啊！嗰日咧，我哋其實有幾十個 presenter 咧，係會 present 翻佢哋喺醫生同埋喺護士咧有好多唔同嘅研究。咁就嗰日我自己就會講一講翻 COVID-19 對香港家庭同埋小朋友嗰個發展嘅影響。Professor Jason Yam 香港眼科醫院咧就會講一講翻咧就 COVID-19 對眼睛同埋細路仔視力嗰個影響。咁希望咧就大家咧就之後會收到我哋嗰啲相關嘅資料咧就多啲參與，可以 physically 去兒童醫院支持我哋。喺10月30號星期六晏晝1點鐘，但係亦都可以 online 去 join in 咧，我哋有啲 session 歡迎大家嘅。因為我哋有一個 joint scientific 嘅原因咧，所以11月我哋嘅hot talk in pediatrics 咧，我哋會暫停一次。下一次我哋 hot talk in pediatrics 開咧會喺12月舉行，所以遲少少咧，我會將 update 嘅資料再 send 俾大家。當然啦，今日咧我哋會得到咗Professor Wong 嘅 permission 之後咧，就會將今日個 talk 個 video 咧就 send 翻俾大家。咁就希望大家如果有啲咩需要 update 嘅話咧，Professor Wong 應該都會再 send 翻啲新嘅資料俾我哋。咁就 再一次多謝大家出席我哋今日嘅 Hot Talk in Pediatrics。祝大家有一個非常之平安亦都愉快嘅晚上。好，拜拜。
拜拜，
拜拜，Ian，唔該晒。
唔該晒，拜拜。